I'll just go ahead and
All
mute
righty, so
everybody.
we're doing that now. I was hoping to get. Let's see.
Who's
I'm not
beeping?
sure who that is, but we're about to mute everybody, so it doesn't matter.
All right.
Anyway, so Graham has had a pretty good introduction. I was hoping maybe Steph might say a word, but it turns out she just worked in the same area, and I thought you might have been friends, whatever. But Graham is a scientist there at Eli Lilly. He was got his PhD, I guess, from Duke, and then moved back to home. I didn't know that, so that's great. So we're looking forward to it. Now, Dave, why don't you make any any protocol remarks you want to, and then mute everybody.
Well, I think you've pretty much covered it all. I'm just going to go ahead and mute them. And if you have anything you really have to say, you can unmute yourself. So, and when it's all over, I don't have the ability for some reason to unmute everybody. So you'll have to unmute yourself.
So now,
here you go.
let me, Graham, you're going to have to unmute yourself.
Okay, I think that worked. Let me see if I can share the screen. I think whoever's hosting has to let me be able to share my screen too. I can't hear you now either because you muted yourself.
Okay, let's see. I can see, I have a lot of screens here for some reason. Let's see.
Dave, I thought I just made it so he could share it.
I think, yeah, you're the host, so I guess you're the one that has to do that.
I got it.
So,
all right. Can you see my screen now?
Yes.
Perfect. Okay. So yeah, I appreciate the opportunity to come and talk to all of you and with you, because I feel like this can be more of a conversation if you want to. And so thank you for the wonderful image for saying to keep calm and get your flu shot. I think that's really important this year. I can't see my slides unless it's on this type of view, but if you want me to go to the full screen thing, then that's fine, just so I know kind of what's coming up in the next slide. But actually, let me do that so it's bigger. Okay, so yeah, I'm currently a research scientist at Eli Lilly. I work in an RNA therapeutics group, and we're basically trying to target a whole bunch of diseases for which it's really hard to target otherwise. And so, like I was said, I was formerly a postdoc at Duke University. I went to Washington University in St. Louis, so I'm also a fan of the Blues, and studied influenza viruses for about 6.5 years. I then moved over to Duke about 2.5 years ago and started studying how the immune system responds to virus infection. So hopefully I can kind of talk about why it's important to get vaccines, and then also some of the complications in the healthcare system, and kind of why it's important to get one this year, especially during a pandemic for different respiratory virus. I feel like I need to give a little bit of a disclaimer. I'm a full-time employee of Eli Lilly. I'm working on separate things, so this is not my area of current work, and I'm not involved in any of the ongoing clinical trials for either therapies or vaccines that are related to the current pandemic. I also don't have any financial interest in either influenza virus or coronavirus vaccines or treatments, and everything I'm going to talk about tonight is already publicly available. And if you have specific questions about things, then I can share the resource that I pulled the information from, if you want to do that later. Next slide. Sorry, I'm trying to figure out where to put the participants window. So kind of as I said, the outline for the talk tonight is I'll be talking about the signs and symptoms of respiratory viruses, specifically influenza virus, as well as the SARS coronavirus, although many of you are probably aware of those by now. Talk a little bit about who's getting sick and where right now, both in North Carolina and nationally. And then talk a little bit about what the typical influenza season does to the healthcare environment. Because in a lot of cases, it really does take up a lot of room within emergency rooms, urgent care facilities, and even intensive care units. And as we know already, there are a lot of those resources already being used up by this kind of concurrent pandemic. And because we're going to potentially have an overlapping influenza season with the coronavirus, it'll be really important to take precautions that keep healthcare facilities open. I'll talk a little bit about why it's important to get an influenza vaccine regularly, typically every year, and then why influenza vaccines are important specifically during the COVID-19 pandemic. And as was said earlier, please feel free to stop and ask any questions during the conversation. I want this to be a two-way street rather than me just giving a lecture on slides. And so I think something that's important to look at is kind of the typical landscape of when viruses happen in the US at least. And this is pretty typical of the Northern Hemisphere, US, Canada, as well as Europe and all the way over to Russia and China. Typically, there are viruses that circulate in the winter, specifically influenza viruses, the other human coronaviruses, which cause mild to moderate disease, typically in young people, and then respiratory syncytial virus, which is one of the leading causes of small children going to the ICU and the NICU and PICU, where all the little babies are in incubators. There are other types of viruses that cause respiratory symptoms that are fairly similar that circulate all year round. In the case of the type-specific and spring ones that are listed here, the acronyms that are used are not terribly important, but they cause very similar types of disease, like runny nose, sore throat, kind of things that you would typically associate with just having a cold. And then there are some summer viruses that circulate, which are typically upper respiratory tract infections, although for young kids, there can be other complications like we've seen with kind of like with some of the non-SARS coronaviruses that may be infecting young kids throughout the US this year. I'm gonna try and switch it to the pointer, so maybe that will help. I think what's important to know is that one of the reasons it's really important to get a flu vaccine this year is because the signs and symptoms of the diseases, while some of them can be slightly different or the severity of each of them can be different, they really overlap a lot. They infect the same place in your body when they cause a very similar immune response. So that's why you get a fever and you get chills, why your body tries to cough so that it gets everything out of your respiratory tract. And then that can sometimes lead to shortness of breath and difficulty breathing. All of those things can then lead to fatigue, being tired, not really feeling like going out, even if we could, and then sore throat and other things like that. In more severe cases, muscle pain and body aches can happen, and that's really just a result of your body trying to fight off the virus. Sometimes that gets overblown, and that's why you actually have to go to the hospital. And not just muscle pain in terms of like your arms being sore, but also your lungs can have a similar impact because they're also muscles. What happens then is it leads again to the shortness of breath and difficulty breathing. In some people, they also have headache, and in some people, they have more severe, or I guess what I would call easily visible symptoms, like vomiting and diarrhea, but this isn't really a thing that happens in adults. It may happen in young children who have that symptomology more often. And so I think something that's important to understand is that a lot of people in the US have underlying chronic medical conditions. For people that have things from asthma to obesity, diabetes, or even COPD, for instance, that may have been former smokers or current smokers, they're predisposed to being infected and becoming severely ill. And these are just based on data from the CDC, kind of risk factors, and then the amount of increase in your potential for being hospitalized if you have one of these conditions. And I think for people that have these conditions, or more than one of them, because a lot of people have more than one condition at the same time, it's really important to keep wearing a mask and staying 6 feet apart if they can. And then always wash your hands if you have that available to you, or use disinfectant or hand sanitizer. And then especially in high traffic areas where there are a lot of people congregating, for instance, it's important to disinfect and clean areas that have a high rate of touch. So like handrails or buttons on credit card machines and things like that, because those are areas where people may have accidentally wiped their face or coughed onto their hands and then spread that way. And the virus can persist on those surfaces for a long period of time. I'm not saying days, although in some cases that's true, but if you think about some like local business for an 8-hour workday that may have hundreds of people, with the current amount of people that are infected in our communities, there's probably a chance that 1 or 2 of those people may have been infected and be symptomatic and able to transmit the virus, either through coughing directly at you or through contaminating the surface that you'll then go on to touch. I think also what's interesting and important to recognize is that the risk of hospitalization as well as death go up as a function of age. So if we use a kind of model age group of 18 to 29, although, that's just where they set their benchmark, then you can see that younger people are typically protected from either being hospitalized or dying, although we all know that there are certain cases of people who either have compromised immune systems or have other existing issues, that this may not be true. And the same thing happens for people older. So essentially, as a function of every decade that you get older, your risk of being hospitalized goes up another group. And especially in people that are significantly older, 85 and higher, they have a much, much greater chance of having both severe disease and then once they get into the hospital, not coming out. And so I think trying to protect people with non-clinical interventions like wearing a mask and staying away from people that you expect or think may have been infected is something that we should try and strive for. And so I think this is a graphic from Akiko Yosaki at Yale University, kind of talking about how we can go about, without having a vaccine, trying to prevent the spread of the virus, or at least minimize the spread of the virus until we have a vaccine or a better treatment than currently exists. So there are a couple of ways that you can stop the spread of viruses. One is by preventing being in contact with people that have the infection. And that's kind of been one of the goals, although extremely painful on everyone, of the last 6 to 7 months, is trying to prevent the infection of new people, keeping other people away from each other. I admit this is not something that's sustainable, and I think that we need to try and work very hard to get beyond that. But once we do kind of get that in place, you can see here kind of in the middle panel that one of the good things about social distancing is that it can actually just slow the spread of infection, basically by removing infected people from the pool of people that could be infected, or basically keeping them away from each other. And then another part of this is that you take out people who have yet to be infected or have no resistance, so that they can then also slow the spread kind of in this chain link manner. One of the things that everyone is trying really hard on is trying to get an immunization for the coronavirus. And so hopefully that will happen soon. There are lots of candidates going on, and actually in the Triangle area, at least Duke and UNC are doing trials for one or more of the coronavirus vaccines. And I think many of them are still recruiting people to be participants in those trials. And so I can send that information along later if that's something of interest to anyone in the group. And so this is kind of what I was getting at, is currently there are 164 total vaccine candidates, which is honestly a remarkable feat of science, because it typically takes between 5 and 15 years for any single vaccine to be approved. And that's not just like we found the virus, we know we need to make a vaccine. It's going from we now have a candidate to getting through all of the trials. And we're looking at something more on the order of maybe 12 to 18 months since we knew what was causing the disease, which is a really wonderful feat. Again, it's not necessarily great that it's taking so long, but thinking about the normal rate of this is really impressive. There are also over 300 drugs that have been proposed as potential cures or therapies for this. over 275 of them are currently in clinical trials. That represents clinical trials that have already concluded and, for instance, have not been shown to be useful, as well as ones that are currently ongoing. It also means that multiple drugs may be used for different types of people. So one of the things about antiviral therapies is they work best if you give them right after you know that you have an infection. And so one of the things that I think a lot of people are trying to do is accelerate the rate at which drugs can be prescribed. And so that can potentially help in the long run, even with drugs that already show some sign of working, but are typically given to people, at least at the outset of this, as therapy for really severe disease. And in some cases, that's not a huge use, although some of them have proven to be beneficial. Let's see. Okay. And so I just kind of wanted to give a little situation update on North Carolina in the context of the rest of the US. As of this afternoon, there were almost 145,000 cases confirmed in North Carolina. There are some estimates based on a whole bunch of math that I don't want to get into, that these case counts are probably between 8 and 10 times too low relative to what's actually happening. A lot of people have really mild disease, and so they don't seek out to be tested. Other people don't have access to testing, which remains to be an issue. What I think is of note is that there are almost 26,000 cases currently active in North Carolina. And what that means is that these are people who received a positive test without receiving a second negative test or still currently in the hospital recovering. And this is showing kind of the incidence rate. So only about 1.4% of people have received a positive and confirmatory COVID-19 diagnosis, which means that we're not really even close to the potential of having anything like herd immunity, where you would expect a lot of people to have already had it and now be protected. In Wake County specifically, there have been over 12,000 cases and about 116 per 10,000 residents, which is about on par with the rest of the state. It just has a higher population density. And so I think one of the things to think about is how these viruses spread. Some factors like temperature, humidity, and then this is again from Akiko Isaki's lab. And then, the indoor environment can really change how these things behave. The humidity can have influence on this, as well as the air change rate. And I think that that's really important to think about if we're going into places with large groups of people. If you're going into a place with poor ventilation, the things that are expelled from people's mouths will hang out in the air for longer. And then there are other properties of the virus, as well as how you speak out of your mouth, that can influence this in terms of essentially how large the droplets that you expel are. So like things like singing or talking really loudly produce larger droplets, and then they can spray everything a lot longer. Whereas if you're wearing a mask, most of the droplets are broken up and then also prevented from leaving your mouth by the mask itself. And then I guess that may be somewhere to take any questions about the coronavirus itself before getting into why it's important to get a flu vaccine, if there are any things that people want to ask right now. Okay. I'll take silence as no questions at this point.
So if you want some questions now.
Sure, I can't see the chat box right now, so.
Oh, okay. So Dave can come on with us, but while he's doing it, I've got one, and I don't know if you're going to talk about vaccines, but has all this emphasis on corona slowed down the work on getting the regular flu vaccine, which every year we have to have it? And then if you could make some comments on if we're going to likely have to get a shot for the COVID every year, like we have to do for the regular influenza.
Sure. So as to developing coronavirus vaccines, I don't think that there's any evidence that it is going to impact making the vaccine. That said, there are a lot of the similar components and packaging that are required for both of them. And so, like vials to put it into, that may be an impact, but making the vaccine itself is not going to be a huge issue, at least from the stuff that I've seen so far. And could you repeat the second question?
I'll have to think of it again, but we did get one that says, how can you tell the difference between COVID and regular flu?
Okay, so I guess, can I ask a question to clarify your question? So I think there are a couple of ways that you can tell. If I got sick with flu or COVID, I wouldn't be able to tell the difference. I just want to say that right now. There may be a couple of days difference in the amount of time between when you get exposed to one of the viruses and when you start to show symptoms. But in most cases, not everyone's going to know the last time that they got exposed. That's an issue at this point that remains to be resolved. There are ways to diagnose one versus the other. And I guess, are you asking about how you know or how you get diagnosed one way or the other, to Dorothy?
Well, that was a question from someone else, but I would assume the way you would know is you get a test for COVID-19. If you don't have that, then you've got something else.
Yes, I agree. And there are groups trying to make a test that can tell if you have one or the other or both at the same time. I don't know if those have been approved yet. Maybe Stephanie can speak to that because this seems like a little bit more of her area at this point. But I think it's going to be reasonable to do. Kind of like the way that you get like a rapid influenza or strep throat test at the doctor's office. I think that can be accomplished, although it hasn't yet been.
And you just answered another question I had, is that you can get both of them at the same time.
So in theory, yeah. I think there were a lot of, and one of the slides I'll show in a little bit is that essentially all of the preventative measures we've taken to slow down coronavirus from spreading also work for other respiratory viruses. So I'm not saying flu season's not going to happen. It will happen. But similar methods work for similar things. So you could be infected by both, potentially. Yeah, I don't think that can be excluded at all.
I have a question. Can you
Okay.
hear me?
Yes.
Well, looking forward to this fall and getting a flu shot. The thing that is presented of concern for me is that I'm probably the most cautious of this group. And so I don't go into any enclosed setting.
Okay.
And so how do you get a flu shot without exposing yourself to the possibility of COVID by going to get one?
Right. So that is a great question. And so I have a slide at the end that talks about where to go get a flu shot and how to search for places that you would feel comfortable going to.
Are there places that are designated as outdoor, where you don't, like maybe the drive-through thing?
I think that there likely will be. I can't speak to the situation in North Carolina at this point, but I can give you a resource so that you can find where it would be best for you.
Fabulous.
I'd like to throw a comment in. Our church is having an event in September where the flu shot will be given, and I think, Jane, they're going to be given to people sitting in their cars.
Okay.
So I will get that information and give it to you.
Okay. It would also, and I look forward to getting Graham's too, because that, if there's a source, then that means that we can spread that information to family and friends who are out of area.
Yeah, of course.
I have a few questions.
Sure.
What for like a drug or any vaccine trial, like what is the process, generally speaking, since something is suggested to actually getting it to market?
Oh, the process from like
Conception to
conception to, yeah. Okay. So I think I'll use one of the vaccines as kind of the candidate or the thing that we'll talk about. So typically the process is people work in a lab for a really long time and figure out that this might work, and they use non-human animals to test it on, either mice typically or non-human primates, and then show that the candidate actually induces a good immune response in those animals. Once that happens, these things go into what's called a phase 1 trial. And what they do is they try and figure out if it's safe in people. So this typically starts with a group of young people, typically 18 to 55, and they get a shot at a relatively low dose, and then they see if there are any adverse events like injection site swelling, pain, headache, anything worse than that. And if it's determined by an external board, which is not part of the trial itself usually, then it can move on to phase 2, which is looking more at, in a larger group of people, if the vaccine candidate is safe. Typically, phase 1 trials are under 100 people total. Phase 2 trials are probably 3 or 4 times that large. And they look at both safety, and then they kind of look at efficacy, so how well it works. But that typically means they're using some type of like a surrogate marker. So in the case of the coronavirus vaccines, they're looking at your body's ability to produce antibodies against the virus. And at this point, because this thing's only 7 months old, it's not completely clear what the right way to determine if something will be effective moving forward is. And so that's why we need to do phase 3 studies, which are both monitoring again for safety, but also looking at efficacy. So these are large trials. Most of the US based phase 3 studies for vaccines here are over, well, 30,000, I think, is their goal for enrollment. So they're going to have a group of people that gets the vaccine and a group of people that gets a placebo. And then they'll look at the rate of infection among people that got the placebo and see if there's a reduction in that rate for people that got the actual vaccine. And then after that, there are follow-up studies that go on. The timeline for all of these things has been compressed greatly in this case, by like probably 4 or 5 times what it would actually happen for other viruses, for sure.
I have a follow-up question that's along the lines of that. Since the timeline is so compressed and there's so much money and so many resources being allocated to getting to a vaccine, do you think that it might be too rushed for something safe to be developed? Since, I mean, a lot of these things, like I said, it's going to take a lot of time and a lot of money to develop.
Right. So I think that one of the good things about this situation is that everyone has decided to do all of this at risk, which means that they are putting their things into trials and making all the vaccine, even if it's not going to actually be approved and work. So a lot of the companies have invested lots of money or gotten money from the government or other philanthropic sources to basically go through trials, and even if it fails, then they've done everything that they would have otherwise. They just shelve it and move on. So I think one of the good things about having so many candidates is that the likelihood for one of them working is much greater. And so I can't speak to any of the individual ones. I'm not familiar enough with the data, and I don't want to like push people to go to one or the other, because I can't make a claim about how good they are yet because the phase 3 hasn't been done. And I think that we'll see in the probably next 4 to 6 months we'll have all of the information about that. The phase two studies will have been completed on safety, like direct safety. And then I think that they'll move in and analyze the phase 3 data to see how useful they are. So I think that while it's accelerated from phase 1 to the end of phase 3, I think that they're going to do all of the appropriate things within that time frame. There are just so many more resources being thrown at this, and like power to try and get everything back to normal, that I think that everything's going to be fine. I hope so, at least. Does that answer the question?
Yes, thank you.
Sure. Cool. How are we doing on time? I feel like we're getting kind of close.
How many more slides do you have?
I can make it quick, I guess. Yeah.
Well,
don't
I don't want to. I mean, this is pretty valuable. So let's go on for a few minutes, and then we'll check with time.
Okay. So I guess I just want to get some background on influenza viruses. I think, as most people have heard, they circulate in diverse hosts, like birds, pigs, and these can transmit viruses to people. This happens all over the place all the time, but usually the virus can actually infect us well. So we have our own brand of influenza viruses. One of the issues with this is that the virus basically increases its genetic diversity because it can infect more people, mutate more rapidly, and then cause disease in different areas of the human population. And this all results in the introduction of new viruses to people. And again, just like the coronavirus, it spreads through respiratory droplets. And there have been pandemics in the past. And they use similar methods like masking and physical distance to try and slow down the spread. Pandemic flus emerge rapidly. There have been a number of them in the last century and a little bit beyond that are well documented and have caused big issues, kind of like this virus is causing now. And so this slide's really busy, but I think it displays kind of one of the principles of why we need to get a flu vaccine every year, is that the influenza virus particle over here is decorated with a couple of proteins on the edge. One is hemagglutinin and one is neuraminidase. You may have heard of like H1N1 or H3N2, and these just refer to certain types of each of those proteins. And so there are, I think at this point, 17 hemagglutinins and 11 neuraminases. Many of those don't circulate in people, but there are a couple that repeatedly come back, like H1N1 and H3N2, that cause issues. And so what can happen is, because this virus replicates a lot faster than, say, like humans are born and go on, is that basically the RNA can mutate in the genome. And this gives rise to new proteins. And sometimes what can happen is that our body's immune response, if they've never seen these things before, basically doesn't think that we've ever been infected with flu, and that can be an issue. These are just some kind of pretty pictures from a paper showing, again, the structure of the virus. This is a really zoomed in image of the virus itself. And you can see that it's studded with protein on the surface, which are used to attach to cells. And then your body basically makes antibodies to prevent these from binding to your cells so that it can never get in and cause disease. And this is kind of just looking over time at why we actually need to get new or renewed vaccines for influenza. This is a paper from Scott Hensley's lab, Ben Chambers, who's actually, well, he may not still be at Duke, but I think he got a job somewhere else. And this is showing the rate of evolution of human H3N2 over time. One of the things that happens is that you accumulate differences in the surface of the protein, just through chance and transmission and the existence of immunity that was pre-existing. One of the things that happens is, if you look at this little surface representation, sorry, it's kind of hard to see here, is that you can have essentially an antibody, which is depicted by this black shape here, and it can bind to the protein here. one thing that can happen is that through these mutations, you prevent the binding of the antibody. And this is one of the reasons we need to get a new vaccine every year, is that you need to be able to refresh your memory, essentially. So I just wanted to share kind of the last couple years of the flu season. This is showing the percent of people who went to a primary care physician or urgent care facility reporting symptoms of influenza-like illness. So what you can see is the flu season typically starts at the end of October, although sometimes in September, and then proceeds through about the end of March. This has been true for essentially the last 10 years of the virus, aside from the 2009 pandemic, which is shown in gray over here on the left. And so this is a typical pattern that we've seen repeatedly. And this is just kind of an age breakdown of who goes for those visits. Typically, it's young kids. Their parents may think that they're, coughing more than often, or they're sniffly, so they take them to the pediatrician. And actually, what's interesting is that the percentage of people who go to these places decreases with age. And so this could be for a couple of reasons. One, people just brush off symptoms like I've had this before, something like that. I don't want to get into any ideas about that because I don't know why. But yeah, something that I think is important to note is that this is showing the percent of all deaths in the US over the course of the last few years. And what you can see everywhere that there's this area between 50 and 10 along the bottom area this is essentially New Year's, which is the peak of influenza season. You can see that a lot of people get sick and die from pneumonia and influenza around the same time every year. 2017 to 2018 was a particularly bad influenza year. But this is showing what happened in early of this year. And this is not specifically influenza mortality, but it's all respiratory distress in the US. And you can see that there's this massive peak caused by the onset of the coronavirus pandemic. And this was about March and April, where there was the massive epidemic, both in New York, Washington, and then in a lot of kind of permanent home care facilities or nursing homes throughout the country. And this has dropped a little bit, but this is an outdated graph, and sorry to say that the rate of death is going up again, which is odd this time of year.
Graham, can I ask a question?
Yeah.
And this is from a couple of slides before I just now got in. So on the normal flu vaccine, I know sometimes they give you a single, sometimes they give you a double shot. Shingles takes 2 shots for the vaccine. I've heard the coronavirus is going to take 2. So what's the difference in all that, for having a normal shot, a double shot, or actually having to have 2 shots?
Yeah. So I guess the way that you could think about it is, one, you're like telling your body to read a book, and it's reading the instructions for figuring out how to respond to the virus. The second time that you get a shot, or the booster shot, you're basically reading all the instructions again, but then like being able to talk about it to other people. So it's kind of like the watch, learn, do kind of like mentality, where basically your body has to see something for the first time and then mount a better response to it. And so I think, one of the reasons that we really want to be sure that we're getting a robust immune response to the coronavirus is we don't know what's going to happen next year. We don't know if it's going to have to be vaccinated for seasonally like influenza is. So I think that's part of it. I can't really speak to the differences with shingles vaccine because it's not an area that I've studied, and I don't want to say something that's either misleading or untrue just because I don't know about it.
Okay, are we towards the end?
Yeah, we got like 2 slides.
Okay.
Cool. this is just showing that essentially as people age, they're more likely to end up in the hospital. Sorry, this graph is small, but it's from the CDC. And so you can see that as you age, the blue line is over 85, and then it drops. A larger proportion of the population is hospitalized over the course of the season. And this is just a summary of kind of the stats from last year, showing that there were between 400 and 750,000 flu hospitalizations, which kind of gets to the idea that we're already running at about half of our capacity for ICU beds and inpatient hospital beds in general. And this is taken from the North Carolina dashboard. And so we don't really have a lot of room for error when it comes to the influenza season. So we need to be able to keep people out of the ICU, potentially by getting a flu vaccine, hopefully, and then allow all these things to be there for the coronavirus patients in case there's not a good vaccine at that point. You can skip that. I think something that I wanted to touch on is that the flu vaccine is not 100% effective. But if you're thinking about 90% of the population that is susceptible to the coronavirus, and then we can reduce that by half in terms of people that are also accessing the healthcare system for influenza diseases, then that can make a big difference. And that's one of the reasons that I think people should really consider getting the flu vaccine. Some good news, though, is that last year, North Carolina was the 5th best state in the country for getting the flu shot. 55% of people got one. Of course, there's room for improvement, but it's better than being on the left end of that graph. I can send this information about what the recommended flu vaccines are, but there are a lot of varieties made for people with different desires in terms of what they want given their health history. And then something that was spoken about earlier is how can we actually, effectively get a flu shot during the pandemic. And the CDC actually has some relatively good information about this. I think what I would do, if possible, is look for local guidance on where things will be. And using vaccinefinder.org, you can go and try and find all the areas around you that actually have a good flu shot system set up. I don't know if they'll have information on it, if it will be outside, for instance, but you can probably at least find out where they'll be and give that place a call to see if they have any information about that. So that kind of wraps that up, and just wanted to show you kind of the coronavirus that we're up against and how we can hopefully make antibodies against this with vaccines. So I guess I'll end that there. Sorry for going over on time.
Well, could I, regardless we're over, could I ask a question?
Of course.
Really, if you look at what happened, what February, March, or March, April with the big peak there.
Mm-hmm.
Okay, so if big peaks happen around the first of the year, right in the holiday season, is that right, normally?
Yeah, let me go back a couple slides.
Well,
Or,
you were showing the one like that showed from the 2017, it was high, and then
yeah, here.
there, that one.
Okay.
Okay, so now what we're looking at, and I think, this is like the terror that we're hearing in you experts' voices, is, we've got these like incredibly high peaks at an off time of year with COVID. And we're going into flu season. What if we don't get this? What if we don't get the curve down? which is not looking good because of the behavior of our fellow citizens. So, you know, what if we don't get it down, or let's say we get it down half of the way, and then we hit like a really hard flu season?
That would be devastating.
And well, you know, it is devastating, and that's what we hear. But what does this mean in reality? What really is the thing that we're looking at, so that people actually get what that means?
Yeah. So I think one of the things that could happen, and I really don't want this to happen, is that if we do have a really bad flu season, that would probably account for about the same amount of hospital capacity that we're seeing in the end of summer with coronavirus. So if that's the case, and we still have high transmission of the coronavirus, then we'll probably max out our ICU capacity in a lot of places. And I think that what could happen then is a lot of people won't get appropriate care. And
So basically, doctors are going to have to decide who lives and dies by who they assess has the best chance.
so,
That's really it, isn't it?
Yeah, I'm gonna have to jump in here. And by the way, if you really want to know all that, Jane, there's a good guy over in England, Dr. David Campbell, I think his name is, because this is going on all over the world. So we're going to have to cut off here. I hate to do this, but it's we've gone a good deal over.
okay.
Yes,
Graham,
but
I
you're
want-
really right at the very point of what the issue is, and it isn't. No one's listening to the doctor in England. I want to know what we really can look at here.
So I think really briefly, I think hospitals will have an issue with capacity if, if people don't get their flu shot, or if, no one abides by either wearing a mask or social distancing. I think that could be really, I'm not optimistic that will happen, but that's as much as I can say. I'm not.
So what we can, one of the things that we can do, aside from, us all doing our thing by wearing our masks and distancing, blah, blah, blah. One of the things that we can do to keep this from going out of control is actually to get the flu shot.
I mean, that would hopefully reduce the amount of people that need to go to the hospital.
Right.
Yes, I think that's one of the best strategies.
Yeah. So Jane, this guy I was talking about does a daily show, but in India, for instance, there's places where their beds are full and they just won't accept patients. Yeah, it's a horror story. Hopefully they don't have a good medical system there as we do, but in different places it's doing it all over. But we are going to have to cut this off. Graham, thank you very much.
Bill,
Yes.
I have one quick question. Is it too early now to get flu shot, or are they already out for this year, the regular flu shots?
So I know that they are being delivered to pharmacies, or have been. My parents got there last week.
Okay.
And so they should be available at least soon if they're not yet.
Okay, thanks.
Yeah, I called Walgreens. They're not in yet, but they said it'd be pretty soon. And Walgreens will be giving them, just an FYI.
CVS, I don't know if CVS is available, but yeah, but that's what we're going to have to do, is we're going to have to call and like Shirley said, if there's special events, I think what I'm hearing is people saying get them in August or as soon as you can, and I normally would wait till October, but they're saying get them early is what I'm hearing. And
We normally get ours at CVS in August, so I'll call and see if they've got them.
yeah.
I would like to ask the speaker or maybe you already have it, Bill, but this particular slide that is on there that shows those peaks, the one that's up there right now, I'd like to have just that slide to, to forward to people that I'm encouraging to.
I was going to ask Graham if I have a copy of his presentation. I was going to ask him if it's okay to share it. Graham, is it?
Yeah. Yeah, you can share with the group. That's fine.
Yeah. And
everything that I've shown is publicly available, and most of it's on the CDC website.
And if you want just that slide, I can cut that out for you and just give you that one slide.
That'd be great. Just to, yeah, it's a really useful, I think, to explain to people why they need to go get that flu shot now.
Yeah, and that was really the punchline we wanted to make. So, Graham, thank you very much. I will be in touch with you, Graham, because I want to send you a letter of thanks, and also got to send you a couple of goodies from the club. And so I'll be asking for a mailing address. If anybody, I have Graham's email address. We don't want to inundate him, but if anybody has a question, I can forward it on to him. Not sure after this, he's probably going back to work. Okay. All right. So thank you very much. You want to take your presentation down there?
Very much. All right. I'll sign off and have a nice rest of your meeting.
Okay. Thank you very much. Appreciate it.
All right. Bye.
Okay. All righty. And I'm going to